Assalamu alaikum. Today we are going to discuss a very important type of cancer which has a significant impact on women health and well-being as well as their social lives. Breast cancer. Before we go into this topic, let us review the breast anatomy. The breast is mainly made of adipose and connective tissues. Within this tissue, there are 15 to 20 lobes. Each lobe is made of multiple lobules to make milk. And each lobule is drained by lactiferous or milk duct into the nipple, which is surrounded by the areola. Our interest is the lobules and their ducts because they're going to be the source of breast cancer. Also within the breast tissues are multiple delicate lymphatic channels that drain the lymphatic fluid into lymph nodes, mainly in the axilla. And each portion or quadrant of the breast is drained by a very specific lymph node called sentinel lymph nodes. Later on, we'll learn about the importance of the sentinel lymph node in the natural history of breast cancer and the treatment. Breast cancer is the most common cancer among women, forming 27% of women and less than 1% of men malignancies. It is the second cause of cancer death in women after lung cancer. Breast cancer is more common in Western countries and Northern Europe, more than in Asia and Sub-Saharan Africa. Of course, the incidence varies from country to country and region to region. This slide lists factors that may increase risk of breast cancer. Increased weight and body fat are considered high risk for postmenopausal women, but lower risk in premenopausal. Here are the rest of the risk factors, including hormone replacement therapy. There are some factors may play a role in protecting against breast cancer, such as breastfeeding, exercise, weight loss in postmenopausal, and low-fat dietary pattern in postmenopausal. Inconclusive factors are listed here. Let us move into presentation of breast cancer. Symptoms and signs of breast cancer are listed here. Of course, breast cancer could present to us as an abnormal mammogram. This leads us into the screening mammography. Screening mammogram is for asymptomatic healthy women. Mammogram decreases breast cancer related death. Radiation from mammogram is equivalent to a dose received from natural background radiation over 3 months. Digital breast tomosynthesis, or what is called 3D mammography, is better because it increases cancer detection rates. especially in young women with dense breasts. What's the difference between a screening mammogram and diagnostic mammogram? In a screening mammogram, we only obtain few views, and in diagnostic mammogram, we add extra views. So it is done if the screening mammogram shows some abnormalities requiring more views, or if the patient or the woman has symptoms. Whenever we talk about mammogram, two questions are raised. At what age mammogram should be initiated and how often? To answer these two questions, we divide women into three groups. Group number one is an average risk group with less than 15% lifetime risk of breast cancer. Those are women without personal and or family history of breast and or ovarian cancer. For this group, there are two opinions. The National Comprehensive Cancer Network and American College of Radiology, they recommend initiating mammography at age of 40, and it is every year. ACP, American College of Physicians, U.S. Preventive Services Task Force, and American Academy of Family Physicians, they recommend initiating mammography at age of 50 until 74, and it is every 2 years instead of every year. After that, they recommend the same every 2-year mammography, but only for women with life expectancy more than 10 years or more. Of course, they don't recommend mammography for this group before age of 40. Between 40 to 49, they said should be individualized or case by case. What about clinical and self-breast exam? This practice is not part of the screening program. However, the WHO encourages this practice for women at age of 50 to 69, especially in low resources and weak health system like ours. And of course, they recommend or encourages breast health awareness. We cannot mention breast cancer awareness without mentioning Sadagat. So let us salute Sadagat for their exceptional, amazing work in this area. تحية لصدقات. The second group are women with 15 to 20% lifetime risk of breast cancer or moderate risk group. Those are women with breast cancer in first degree relatives without a known genetic syndrome like BRCA. For this group, is still the recommendation is same as the previous group, average risk group. The third group is high risk group. That means more than 20% lifetime risk of breast cancer. This group includes women with personal history of breast or ovarian cancer, family history of ovarian cancer, strong family history of breast cancer. That means more than two first degree relatives, and ancestry Ashkenazi. And BRCA positive or other susceptibility genes listed in this slide. So for this high-risk group, the recommendation is actually simply refer them to high-risk screening clinic for evaluation, surveillance, risk reduction like chemo prevention by using, for example, tamoxifen, or even prophylactic surgery for simple mastectomies and oophorectomy after they finish with their pregnancies, and of course could offer them genetic testing and genetic counseling. So this is a special group. In this group also is women with history of chest irradiation, like Hodgkin lymphoma patients treated with radiation. For this specific subset of patients, we recommend mammogram or MRI because they're young patients, uh, 8 to 10 years after treatment or at age of 40. What are the criteria to refer patients for genetic counseling and testing? Personal history of female breast cancer at age of less than 45, maybe 50, or at any age if Ashkenazi Jewish, and any patient with two primary breast cancers, but the first has to be less than 50, not just two primaries after that age. The second is male breast cancer and family history of ovarian, or of course, personal history of ovarian cancer, and triple negative breast cancer, triple negative ER, PR, HER2. We'll learn about it later on, but triple negative breast cancer at age less than 60. Or breast cancer at any age plus relative with breast cancer at age less than 50, or metastatic prostate cancer at any age, or exocrine pancreatic cancer. What are the mammographic findings? The mammogram may show masses, calcifications, asymmetries, or architectural distortions, but the most specific findings for malignancy are speculated focal mass, which has a very high positive predictive value, or density of non-calcified mass, calcifications, especially group microcalcifications, or pleomorphic fine linear branching microcalcifications. Sometimes we do see benign calcifications, especially vascular and skin calcifications. Sometimes we do use MRI of the breast instead of mammography to increase sensitivity and specificity. This is specifically for genetic mutation, for patients with genetic mutations BRCA 1 or 2, or a or patient with first degree relative of gene mutation carrier BRCA. Also, MRI could play a role. Patients with thoracic radiation when they are young, if they are young at age of 10 to 30 years. Patients with lobular carcinoma in situ or atypical lobular hyperplasia, or patients with atypical ductal hyperplasia. Since we are done with the presentation, let us move to the diagnosis, the clinical diagnosis. Simply, the breast cancer could start by an abnormal screening mammogram or even an MRI, or could start by a palpable mass either by the patient herself or the physician. For patients 30 years and older, we typically start by diagnostic mammogram and ultrasound if not already done. So for a negative diagnostic mammogram and ultrasound, we just keep monitoring clinically or by imaging. For a negative diagnostic mammogram, but an abnormal ultrasound that shows a mass or a complex cyst, either we keep monitoring or go ahead with the core biopsy, especially if clinically suspicious ultrasound finding. The third scenario is an abnormal diagnostic mammogram and ultrasound suspicious for malignancy. Those patients should undergo ultrasound guided biopsy or other kinds of biopsies. For patients younger, less than 30 years, ultrasound is preferred because breast is dense. For low clinical suspicion, we either observe the lump for 1 to 2 menstrual cycles, because it could be just simply a benign cyst or lump. If the mass or the lump persists after the 2 menstrual cycles, then we repeat the ultrasound. But if the mass resolves, we continue the screening or monitoring. Now, we need a tissue sampling. There are few options to obtain a tissue for definitive diagnosis, either aspiration, fine needle aspiration, skin punch biopsy, core needle biopsy, or excisional biopsy, wire guided excisional biopsy. If the pathologic finding is benign, but it has to be concordant with the imaging, then we continue the screening or physical exam and imaging every 6 to 12 months. But if the findings are intermediate, benign, and intermediate or benign plus discordant imaging, or if the pathologic finding is atypical ductal hyperplasia or polymorphic lobular carcinoma in situ, or other histologies such as phylloids or papillary, then that lump should be excised. Lobular carcinoma in situ or atypical lobular hyperplasia, if it is discordant with the imaging, then it should be excised. But if it is concordant with imaging, we could keep monitoring with physical exam, with or without ultrasound and or mammogram every 6 to 12 months, or if not comfortable, we can just excise it. But if the pathology is clearly malignant cells, then the story is different. And we go to the next step. The next step is pathology review. And the pathology could show one of the following: either invasive ductal carcinoma, which is a majority, 76% of breast cancer is invasive ductal carcinoma, or it could be invasive lobular carcinoma, about 8%, or it could be a mix, about 7%. By the way, the invasive ductal carcinoma and invasive lobular carcinoma, they behave the same and they have similar prognosis. But the pathology could show one of the rare types like pure tubular, mucinous, or colloid, or papillary. Those are usually small tumors with negative lymph nodes, slow growing tumors. They have favorable prognosis and they are typically estrogen dependent and HER2 negative. There is another rare type which is pure typical medullary carcinoma. This type has a better prognosis than ductal, and it has a favorable prognosis similar to tubular and colloid. The problem is because it is rare and uncommon, it may become difficult to diagnose pathologically. So it's recommended to treat same as invasive ductal carcinoma. Prognostic factors. After we made the pathologic diagnosis, and then we want to see how this cancer could behave in the future. So we need to stratify the patients based on prognostic factors. The regional lymph nodes, involvement or no involvement by the cancer, is the most important prognostic factor. So if the lymph nodes are negative for cancer, the risk of cancer is still the risk of cancer coming back is still there, and it is up to 20 to 30%. But if any lymph node is involved, even one lymph node is involved, the risk jump up to 50 or maybe 70% risk of recurrence or relapse. And this is dependent on the number of the lymph nodes. The more lymph nodes involved, the more risk of cancer coming back. For example, if there are 10 lymph nodes involved, the risk is as high as 80% relapse and micro or macro metastasis. The second prognostic factor is the tumor size. The smaller the tumor, the lower risk, the bigger the tumor, the higher risk. We usually use a cutoff of 1 centimeter. Less than 1 centimeter is better than more than 1 centimeter, and so on. Estrogen and progesterone status. If the cancer is estrogen or progesterone dependent, it has a better prognosis than a cancer which is ER or PR negative. The grade, the lower the grade is better, of course, than the higher the grade. Age, the younger, the younger is worse. The older patient, they have better prognosis, and we use the cutoff of 35. Ki67 or proliferative index, the lower the proliferative index is better than higher, of course. And the HER2 status. HER2 negative breast cancer, they have better prognosis than HER2 overexpressed breast cancer. Then, then after that, we move to the workup, and here the list of the workup. Start from HMP all the way to the scans, bone scan, CT scan. I want to remind that is breast cancer overexpressing HER2. We should include brain MRI because of the higher tendency of brain metastasis, and also PET scan is not a routine test for breast cancer. Staging, very complicated. This is the TN. So to make it simple, I made this drawing to simplify the staging. So if the cancer only confined to the lactiferous duct, the milk duct, this is stage 0, ductal carcinoma inside of it. If it is confined, if the cancer cells are confined within the lobule without invading the wall of the lobule, this is a lobular carcinoma insider. It used to be stage 0, but now is removed from the staging. If the tumor invades the wall of the duct to the surroundings, but is still 2 centimeters or less in size, this is stage 1 breast cancer. If the cancer continues to grow and it is more than 2 centimeters, but less than 5 centimeters, and may reach the lymph nodes in the axilla, but has to be less than 4 lymph nodes. So 1 to 3 lymph nodes, or if the tumor is more than 5 centimeters in size, this is stage 2. But if the tumor reach multiple lymph nodes, more than 4, this is stage 3. But if the tumor reach supraclavicular lymph nodes, regardless of the size, this is stage 3C breast cancer. Of course, if the cancer reach any distant organ, lung, liver, bone, brain, that's stage 4, of course. This slide just displays how breast cancer staging has been evolving. It was started by the simple anatomic staging, then moved to clinical prognostic staging, and finally to pathologic prognostic staging after incorporation of the tumor biomarkers and the grade. Now, let us move forward and discuss management of breast cancer. I will try my best to simplify it and walk you through the management step by step. We'll start the management with non-metastatic breast cancer. Generally, the management is surgery, which is either mastectomy or lumpectomy. Second, radiation therapy. Third, systemic therapy, which includes endocrine therapy, chemotherapy, targeted therapy, and immune therapy. The sequence may change, depends on stage and other factors. Stage 0, ductal carcinoma in situ. The treatment either breast conserving therapy, which is lumpectomy with the negative margin, followed by adjuvant radiation therapy, or mastectomy with sentinel lymph node dissection. And after surgery, we usually treat those patients with endocrine therapy, tamoxifen or aromatase inhibitor, tamoxifen for 10 years, aromatase inhibitors for 5 years. Lobular carcinoma in situ. This is now considered a benign condition and has been removed from the staging system. It is either non-proliferative LCIS or proliferative LCIS without atypia or proliferative with atypia. The atypical ductal hyperplasia, we treat that with excision. Lobular carcinoma in situ, we either observe or excise and put those patients on lifelong active breast cancer surveillance and may give them endocrine therapy, tamoxifen for chemoprevention, as chemoprevention. Now, let's just walk through the treatment of stage 1 to 3 step by step. Again, this is just a reminder of the stage 1, stage 2, stage 3. We talked about those pictures previously. So, surgery. Here are the surgical options. Again, breast conservation, which is lumpectomy, plus sentinel lymph node biopsy, or modified radical mastectomy with sentinel lymph node biopsy, with or without reconstruction. These are the absolute and relative contraindications for breast conservation. As we have mentioned, that the status of the axillary lymph nodes is very important for the natural course of breast cancer and the management. We went through this before. So, lymph node metastasis is considered the most significant prognostic indicator for breast cancer, as we mentioned before. But axillary lymph node dissection is not without complications. So people start looking for an alternative, which is the sentinel lymph node biopsy to minimize surgery in the axilla. So this could be used as an initial evaluation of the axilla, but it is only for patients who do not have palpable or enlarged axillary lymph nodes. This is very important. Axillary lymph node dissection. Axillary lymph node dissection has risk and complications listed here. Restricted range of motion, pain, discomfort, lymphedema, infection, seroma. Because of that, people start looking for an alternative, as we said. It is the sentinel lymph node biopsy. So let's talk about the sentinel lymph node biopsy. This is the technique for the sentinel lymph node biopsy. Basically, we inject the tumor with the methylene blue or an isotope. The isotope or the methylene blue is going to travel into the lymphatic channels to the first lymph node draining the area of the tumor. That lymph node is a sentinel lymph node. The lymphatic mapping for the sentinel lymph node could be done by the blue dye, the methylene blue, and the success rate to identify the sentinel lymph node is up to 83%. But if we use the lymphoscintigraphy, the success rate increase up to 94%. And if you combine both, then the success rate is 97%. And the false negative is anywhere between 0 to 11%. This is all depend on the experience of the surgeon, and the institution. So it is really depends on the training. Who are the candidates for sentinel lymph node biopsy? First of all, the patient should not have a palpable or enlarged axillary lymph node. And the tumor has to be less than 5 centimeters in size. That is stage 1 or 2. If it is going to be done for ductal carcinoma in situ, stage 0, it has to be a high grade or extensive DCIS with the planning for mastectomy, because we may find invasive component within the DCIS. So we don't want to go back again and look for a sentinel lymph node. And of course, those patients should not have had a preoperative chemotherapy or a plan for preoperative chemotherapy. So now we identify the right patient for the for the sentinel lymph node biopsy. The surgeon done with the mapping identify the sentinel lymph node cytopathology, and it is negative. If it is negative, we stop right there, no further surgery. But if it is positive, it was a dilemma, but not anymore, because now we know what to do after the positive, what to do for a positive sentinel lymph node. The other scenario, sentinel lymph node not identified. Honestly, this happened for inexperienced surgeon or in an institution not equipped for this procedure and with no or insufficient training for this procedure. Sentinel lymph node involvement only identified by should be only identified by the standard H&E staining, not by immunohistochemistry. Immunohistochemistry should only be used for equivocal cases. Sentinel lymph node positive by routine IHC immunohistochemistry is not recommended in clinical decision making. Now, what we do when the sentinel lymph node biopsy is positive. This area used to be an area of a lot of debate and confusion because some surgeons used to believe a positive sentinel lymph node biopsy should be followed by axillary lymph node dissection or quote-unquote cleaning the axilla. This area now has been clarified after a large study called Z0011. Based on this study, no axillary lymph node dissection is needed if the patient meet the following criteria. Number one, clinically negative lymph nodes before the procedure, of course, and less than three lymph nodes are positive for the metastasis, and the tumor was stage 1 to 2, pathologic stage 1 to 2, less than 5 centimeter, and the patient committed for whole breast radiation following the lumpectomy. On the other hand, axillary lymph node dissection, quote unquote cleaning the axilla, is recommended if there are 3 or more lymph nodes came back positive for metastasis, or if there are less than 3 lymph nodes positive, but the patient not desire whole breast radiation, or if there is extracapsular extension of the cancer regardless of the number of the positive lymph nodes. Now we move to the second modality of breast cancer treatment, which is radiation therapy. This slide displays the role of radiation therapy after lumpectomy. Clearly it shows that radiation therapy improve the local recurrence in 6 studies. This slide displays the role of radiation therapy after lumpectomy, which make it as good as or equivalent to mastectomy. From these 2 slides, we conclude this: lumpectomy followed by radiation therapy is equal to mastectomy, modified radical mastectomy. Radiation therapy is typically given after lumpectomy, but sometimes and in certain situations we do recommend radiation therapy after mastectomy, and here are the situations. Now we move to the third method of treatment for early stage breast cancer, which is adjuvant systemic therapy, either endocrine therapy or chemotherapy or immunotherapy or targeted therapy. So let's just review those. First, who is a candidate for adjuvant systemic therapy? Healthy women, women with positive lymph nodes, tumors less than 1 centimeter, invasive ductal or invasive lobar carcinoma, tumor more than 3 centimeter for the rare type with the favorable prognosis, tubular papillary amucinous. These are the general rules. And we have to say that data is limited for chemotherapy in elderly women more than 70 years. Before we talk to the patient about their options of the systemic therapy, we have to answer 3 questions. Is the cancer estrogen and or progesterone dependent, ER positive or negative, PR positive or negative, HER2 overexpressed or not? To answer those questions, and after reviewing the pathology, which typically shows most likely ductal, maybe lobular, or maybe mixed, or less likely metaplastic, we check for the hormone status, ER/PR if positive. We check for HER2 if positive, that is group 1, which is triple positive, ER/PR positive, HER2 positive. But if it is ER/PR positive, HER2 negative, that's group 2, or for ER/PR negative, HER2 positive, that's group 3, and the last group is everything negative, which we call triple negative, which carry the worst prognosis among the 4. The first group is breast cancer overexpressing HER2. This includes hormone receptor negative and positive. HER2 status or overexpression overrides the hormonal status because HER2 overexpression is associated with a more aggressive tumor phenotype, and it has more aggressive course and higher relapse and mortality rates. In addition to that, the HER2 protein overexpression and or HER2 gene amplification is not rare. It is 15 to 20% of breast cancer. Patients with tumor overexpressing HER2 are treated with chemotherapy plus anti-HER2 therapy, with or without endocrine therapy based on the hormonal status, ER/PR, positive or negative. The second group of patients are those with hormone-dependent breast cancer, but not overexpressing HER2. HER2 negative, ER/PR positive. Those patients are treated with endocrine therapy as the main treatment. And here are the options of the adjuvant endocrine therapy. Either ovarian function suppression, medically by using gonadotropin releasing hormone agonist, or surgically with ovarectomy, or maybe with radiation therapy. Another hormonal therapy is tamoxifen, which is taken daily, 20 milligrams daily for 10 years. And the third option is aromatase inhibitors for 5, maybe even 10, up to 10 years, and this is only for postmenopausal women. When to add chemotherapy for hormonal dependent breast cancer, HER2 negative. This is based on the magnitude of benefit from the chemotherapy, which depends on the clinical feature of the tumor, the stage. The higher the stage, the likely we give them chemotherapy. The lower the stage may not benefit much from the chemotherapy. Grade, lower grade than versus higher grade. And biologic features based on gene expression of the tumor itself. And we'll talk about this in the next slide. Gene expression profile of the tumor could be performed by using one of the following tests: Oncotype DX, EndoPredict, or MammaPrint. The fourth group of patients are those with triple negative. Those are negative for everything, negative for estrogen, negative for progesterone, and negative for HER2 biomarker. Triple negative breast cancer, which has worse prognosis compared to others. Triple negative breast cancer is basically treated with adjuvant chemotherapy, especially if the tumor is more than 0.5 centimeter, or of course if any lymph node is involved by the cancer. Those patients, by the way, if they receive chemotherapy before surgery and end up with residual tumor, still we give them more chemotherapy. Typically we use oral chemotherapy, Xeloda or capecitabine. These are the chemotherapy options for people who are interested on chemotherapy regimen. Why chemotherapy? Because many studies showed that chemotherapy reduces risk of recurrence by 30% in premenopausal and 20% in postmenopausal patients. Chemotherapy reduces risk of death by 25% in premenopausal and 15% in postmenopausal. Chemotherapy reduces mortality by 20% in general, and that is an 8% benefit in patients with node positive, but only 2% in patients with node negative. Adjuvant therapy for BRCA gene mutation patients. Patients with BRCA gene mutation may benefit from adjuvant PARP inhibitor. PARP is a polyadenosine diphosphate ribose polymerase enzyme, which is an enzyme that repairs DNA damage of the cancer cell. And the drug of choice is olaparib or Lynparza, which is an oral therapy. Any role for systemic therapy, endocrine, immune therapy, and or chemotherapy prior to surgery, new adjuvant therapy. Why we need to use systemic therapy prior to surgery? We do use systemic therapy, chemotherapy, endocrine therapy, or targeted therapy before surgery to downstage or to allow for a higher rate of breast preservation. Another reason is to assess tumor response to particular drug or drugs. The third reason, or it has been noticed that pathologic complete response is a powerful surrogate of long-term disease-free survival. Now we are done with the management of non-metastatic breast cancer, so let us discuss management of metastatic. We use the same strategies and stratification to treat metastatic breast cancer. Of course, we check for the same biomarkers, HER2, ER, PR status. So for patients who are ER positive, PR positive, HER2 negative, usually we treat them with endocrine therapy, tamoxifen or aromatase inhibitors, as we said, only for postmenopausal women, or ovarian function suppression, or fulvestrant or phosphodex injections. To increase the efficacy of the previously mentioned endocrine therapy options, we could add, or actually it is standard to add, targeted agents for a better outcome. One option is to add CDK inhibitors, cyclin-dependent kinase inhibitors, and there are 3 available drugs listed here. PI3K inhibitor, PICRA. This is typically used with fulvestrant. Another option is PARP inhibitor, olaparib or Lynparza. This is specifically for patients with BRCA gene mutation. Chemotherapy. We use chemotherapy in 2 situations. Patients with extensive symptomatic visceral metastasis, we use the chemotherapy for fast response, and then after 3 to 6 cycles, we switch back to the endocrine therapy. Remember, we do not use endocrine therapy at the same time with chemotherapy. Or of course, the second scenario, we use the chemotherapy for patients, of course, with refractory disease to endocrine therapy. The second group of patients are those with tumor tumors overexpressing HER2, regardless of the ER or PR status. HER2 positive breast cancer. Here are the options of anti-HER2 therapy, which could be in addition to chemotherapy or addition to endocrine therapy. The third group of patients are those with triple negative, negative for everything, negative for HER2, negative for ER, negative for PR, which has the worst prognosis. Those patients are treated with chemotherapy because there is nothing to target. However, for patients with not rapidly progressive disease, we could try PD-L1 inhibitors for patients with PD-L1 positive disease, and we use the immune therapy or checkpoint inhibitor. Patients with germinal BRCA mutation, we use PARP inhibitor. Finally, let us go over certain situations of breast cancer. Inflammatory breast cancer. Inflammatory breast cancer is a clinical diagnosis. The characteristic of inflammatory breast cancer is the triad of skin erythema affecting more than 1/3 of the breast. Second, diffuse breast warmth. Third, skin edema and ridging, PDGO orange, which is caused by engorged dermal lymphatic channels. Other characteristic of inflammatory breast cancer is nipple retraction. Those patients typically has positive or enlarged axillary lymph nodes, and up to 30% of them present with metastasis. And remember, inflammatory breast cancer may mimic cellulitis and mastitis. Pathology of inflammatory breast cancer is characterized by dermal lymphatic involvement. 70% of clinically inflammatory breast cancer has this feature. The treatment of inflammatory breast cancer is very standard, which is chemotherapy upfront. So if you see breast cancer patient and you are a surgeon, do not take those patients to surgery upfront because they don't do well. Send them to medical oncology for neoadjuvant chemotherapy first, then bring them back for surgery, which is modified radical mastectomy, and that should be followed by radiation therapy, even for complete pathologic responders. So this is very standard. Chemotherapy first, surgery, radiation to follow, and if they have ER, PR positive or HER2 positive, they should receive those kind of targeted therapy. Finally, and this is the last slide, male breast cancer. Male breast cancer is very rare. It is less than 1% of cancers in men. The approach to male breast cancer is almost mirror image to women breast cancer. The one thing that I want to point out is when we use endocrine therapy for ER/PR male breast cancer, we use tamoxifen rather than aromatase inhibitors because of possible testicular production of estrogen. So if we want to use tamoxifen, or tamoxifen is contraindicated for whatever reason, then aromatase inhibitors should be given along with gonadotropin releasing hormone agonist. No doubt, it has been a very long session with a lot of information and details. So let us summarize the whole thing into 2 slides, if possible. Take home message number 1: breast cancer is a curable disease, of course, if detected and treated early and properly. Early detection saves life by doing screening mammography to our patients. Monthly self-breast exam with regular physical exam is an acceptable practice in a low resources and weak health system like ours. Be aware of hereditary breast cancer. So, counsel young patients and those with family history of breast and or ovarian cancer for genetic testing, especially BRCA. Take, take home message number 2. Axillary lymph node status is the most important prognostic factor in breast cancer. Sentinel lymph node procedure should be performed in all patients with early stage breast cancer who meet the criteria for this special procedure. HER2 positive breast cancer is associated with an aggressive tumor phenotype and clinical course. Multiple options of anti-HER2 therapy are available nowadays for those patients. This therapy has proven to improve disease-free survival and overall survival. Patients with ER-positive, HER2-negative early-stage breast cancer should be evaluated with gene expression profile, such as Oncotype DX, before initiation of any adjuvant cytotoxic chemotherapy, simply because they may not need it. Triple-negative breast cancer is a special entity with limited systemic therapy options due to the lack of common actionable biomarkers. Finally, breast conservation with lumpectomy followed by radiation therapy is equivalent to mastectomy. And thank you very much.